You're making me feel so old. Call me
No,
Iris, please.
so much wisdom and reverence. I
Call me Iris. It's good to see you.
know, good to see you too. Good evening, Endo Summit Live, and welcome to one of our favorite evenings in our series on endometriosis. Tonight, we are talking all about the bladder and endometriosis with an incredible team. Please welcome, I think it's like the Brady Bunch, how I have the little squares. Please welcome, joining us from Los Angeles, Dr. Iris Karen Orbach. Dr. Orbach, can you introduce yourself? She's going to turn her volume on.
Thanks, Sally. So I'm Dr. Iris Karen Orbach. I'm so happy to be here and be part of this. And my specialty is basically endometriosis, trained in excision, but what I love to do is look at the whole body and try and understand how all the different components of contribute to pain. And I wrote a book, Beating Endo: How to Reclaim Your Life from Endometriosis. And kind of my passion is to really raise awareness and change the trajectory of those who are suffering, striving for early diagnosis, and helping people understand the disease and like really reclaiming their lives.
Yes, excellent. Thank you for joining us. Also joining us from California this evening is Dr. Saruna Fathatcher. Dr. Saruna, can you introduce yourself?
Yes, I'm Dr. Fathatcher, double fellowship trained in minimally invasive surgery and excision endometriosis, and also urogynecology reconstructive pelvic surgery. And I've been doing excision of endometriosis for now, since fellowship, if what counted, since 2013, so which is almost 10 years. But
can you tell everybody, can you give a little shout out? Who'd you do your fellowship for excision with? I don't know if everybody knows.
Yeah, absolutely. I was in a Center of Endometriosis Care for 1 year with Dr. Kenny Saniovo and Heather, and it was an incredible experience. So yeah, so I've been doing that with the CO2 laser. I like the laser for excision of endometriosis for most of my cases. So I've been doing stage 4 endometriosis, and my office is in Long Beach, but I live in Marina Del Rey. So
awesome.
local.
And also joining us this evening from New York and New Jersey is Dr. Lori Liu. Dr. Liu, welcome from your new practice. Can you introduce yourself a bit?
I'm Dr. Liu. I basically only do endometriosis surgery. I graduated from residency at Lenox Hill in New York in 2016, and then I did a 2-year fellowship, minimally invasive surgery fellowship at the Mayo Clinic with Dr. Javier Magrina, Dr. Megan Wasson, and some other all-stars. And then I moved back to New York, where I've been focusing on endometriosis surgery since 2018. So not as long as everyone else, but really have learned a lot from my mentors, Dr. Orbach and Dr. Vidali and all the big names. So very appreciative to be on this panel.
I don't know if he's coming on screen. Oh, there he is. Please welcome from, I believe, West Virginia, Dr. Maurice Chung. Dr. Chung, do you want to introduce yourself? Mike. You have to unmute. 2024, people.
All
2024.
Right, 2024.
Right.
Well, I'm starting out as an excisional surgeon back in the 1990s. I'm a urogynecologist, and now I'm in West Virginia. So I have done a lot of research on the bladder issue. Maybe that's the focus for tonight.
Yes, that is the focus for tonight.
So I'm just here to listen.
Oh, I didn't know that. I just see you. I think like we
I'll have a
invited.
discussion maybe if you want me to say something.
All right. So let's start. We'll start with our team. Patient comes to you, and how do you evaluate what you think may be bladder related pain? What kind of symptoms might somebody have? We'll start with you, Lori.
I think one of the biggest symptoms is when patients tell me when they've been to multiple urologists or they tell me they have recurrent UTIs, I always ask, is it culture like proven UTIs? Like, did a bacteria grow? Most of the time they'll say no, but they've been treated with every antibiotic under the sun. And then I usually ask them, do you notice a pattern to it? Is it worse with your period? Is it worse around ovulation? Do you notice that your urgency, frequency, bladder pain gets worse, during or worsens during different times of the month? And a lot of times that's a huge red flag for me when the patient tells me, yeah, I mean, I feel like I've been to so many different urgent cares and they always just give me an antibiotic. Nothing ever grows. And it just keeps on happening. I have recurrent UTIs. And so that's a huge red flag for me, that it could be something that's not a UTI, it's not an infection. Maybe it's endometriosis, particularly if it's cyclical.
Dr. Saruna, you're Urogyne, I believe. How many
Yeah.
times are people coming to you with urinary symptoms and you have to deduce endometriosis?
That's a very good question. So to answer this question, I actually published a review about 4 decades of urinary tract endometriosis. So I look at the evidence because this is going to be all over the place how you would diagnose the bladder endometriosis or bladder issues in the patient with endometriosis. Can a patient have an endometriosis and can have stress urinary incontinence? Obviously, right? So, but can a patient have overactive bladder and endometriosis? Yes. Can a patient have IC and endometriosis? Yes. So looking at the 4 decades of evidence, which I published the first time in 2015 in AAGL as an abstract, and again this year we updated for 4 decades from 1976 all the way to 2024. We presented in AAGL. Unfortunately, they did not give us the oral presentation as a presentation. That we just had it like a virtual oral presentation, which I do think a lot of people would be benefiting from hearing how to evaluate the urinary tract endometriosis, because that's our daily life. You go into someone's pelvic, and then all of a sudden you see, oh my God, this is the deep infiltrative nodule right there over on top of the urosacral, that affecting the right ureter or left ureter, and now you have to evaluate and try to remove it without even thinking about that, to putting a stent in. So probably Dr. Chung understands it very well because he's also a urogynecologist. For that, I was always curious how to basically come up with the idea how to evaluate endometriosis patients. Number one, I would encourage everybody to read that abstract because it's amazing, and we're actually finishing the manuscript. We're going to submit that to JAMIC soon. Hopefully they're going to accept it or not, I don't know, but we'll try that. We wrote the whole manuscript. It's going to coming up soon. And I want to give you a little bit of feedback. When I see the symptoms of overactive bladder, which aggravated through the menstruation, that is a big sign for me to be ready for bladder endometriosis. Although as a universal policy and as a urogynecologist, I also do a cystoscopy before I take my patient back to OR. So that's one of the tools I use. I also get the MRI. I'm sure a lot of endometriosis specialists, they do a pelvic MRI with and without contrast to see what they're dealing. But most of the time, what we see in the OR is just a scattered endometriosis involvement that is not very deep over the bladder. And believe it or not, that can actually mimic the symptoms of overactive bladder for patients, because stimulating the peritoneum can also stimulating the bladder detrusor muscles. So that's another thing, which I see a lot of IC diagnosis. It's kind of like an overdiagnosed without even knowing that this is interstitial cystitis or not. So they're just going in, how to distend the bladder and coming out, they think this is something good. We already know if somebody, for example, have endometriosis and you do laparoscopy, even if you don't do anything because you actually dilate and distending the abdomen to creating a little bit of a distance between the superficial lesion on people with the low stages of endometriosis, they feel better after laparoscopy for maybe 1 month, for maybe 2 months. But you didn't do anything. You didn't actually treat it in endometriosis. So I do think in that review, when we looked at the 48 years of evidence of the urinary tract endometriosis, we found that urinary tract endometriosis can be involved up to 12% of the endometriosis cases, and sometimes up to 53% of the deep infiltrative endometriosis. Bladder is the most common one, is 85% can be involved. And then the symptoms are very, very, very specific. It's kind of like an overactive bladder symptom. So urgency, frequency, nocturia, and then most importantly, hematuria. I know ACOG came in with the new practice bulletin for hematuria that if women have more than 20, is up to 26 red blood cell is okay if they're reproductive age. But I kind of disagree with that. Going back over my urology book and the AUA, I accepted more than 3 RBCs. I know I'm not going to go against any argument about that. But if I see it, if somebody has 10 RBCs, I'm going to investigate that. I'm going to do a cystoscopy. I'm going to do a CT urogram to maybe make sure that there is no obstruction in upper tract or lower tract. So ureter is the second one can be involved up to 23%. Sorry, I got a phone call from a hospital. Give me 1 second. I ignored that for a second. I did 4 surgeries today, so they're going to keep calling me. So ureter can be involved up to 23%, and we know 50% they can be asymptomatic and can cause kidney failure, a silent renal failure if we don't actually address that. So it's important to always thinking that you have a bladder somehow involvement, that you can have bladder involvement and investigate that. So doing an office cystoscopy would give you some sort of information about the patient. And obviously, I don't know how people doing an ultrasound and diagnose these things by the ultrasound. I'm not that expert with the ultrasound that I can diagnose the bladder endometriosis. However, I do think ultrasound is also very subjective. So I do encourage everybody to please, please, please do MRI of the pelvic and make sure that you don't deal with the deep infiltrative endometriosis, that you don't need a urogynecologist or urologist involvement to help you in that case. And then make sure, I kind of like to excise the endometriosis as much as I can see. I always tell them to be off of a birth control or something like that. And I always try to put the stent on my patient to be able to excise the endometriosis on top of the ureters if I can.
Excellent. We're going to chat because I'm on this patient board with AUA, with the American Urology Association, and I could take that information from that article and run with it. And I have their ear for the first time. Somebody actually is listening to me. So, Dr. Orbuch, you do a very thorough exam and you discuss a lot of things. Do you want to talk a little bit about somebody who comes to your office and you suspect bladder involvement? And bladder involvement, we're going to get into the nitty-gritty of this. Bladder involvement is disease, but bladder involvement is also the way the bladder interacts with the sensory of the pelvis. So what are some things that you look for?
So are you referring to like what symptoms do they have?
Yeah,
first?
that works.
Okay, because I'd love to go to the beginning of it, because the question is like, how do we ask patients questions to really get good answers? And what I've experienced, and this is almost 2 decades of doing this, is that so many patients think it's normal that they get up 2 times a night because they've always gotten up 2 times a night, or they think it's normal to urinate 15 to 17 times a day because they're always urinating that much, or there's this like slow progression. So I like to ask questions in a different way than like a technical doctor, I'm a doctor, would ask a question. So one of the first things I always ask them is, if you're taking a road trip with your friends, who would they stop to urinate for? Who would they stop to go to the bathroom for? And right away they're like, me, I've got the small bladder. They're like, but if I have them, they all fill out the PUF questionnaire before they even come into my office. It's always so underreported, and the number of voids and like that number, but just seeing the pattern kind of gives me an idea how much time to focus on that. So I always ask them that. Like what Lori alluded to, when they say they have these infections, I always ask, did the doctor say, you had an infection the day you went into the office, or did they call you 3 or 4 days later to confirm, yes, it was? And I often will, if I still think it's not an infection, I'll get those cultures and look at it, because the more we're treating someone with antibiotics who doesn't need it, then they have higher likelihood of SIBO and gut issues. And so I'm trying to get to the nitty gritty. I always ask them about, if you urinate, is it a full amount of urine? How long does it take to initiate the stream? Does it stop start? Any urgency, like, oh my God. And I say, you're putting the key in the door and you got to run to the bathroom. I try and make it as simple as possible to get the accurate information. And the one thing that I've really realized in my practice, I have patients who have a lot of bladder symptoms who have no endo on the bladder. Like, once the central nervous system is flared, and which it is, like, I saw 2 consults today. One, we talk about this 10-year diagnostic delay. We're in 2024. This patient had symptoms for 20 years, like 2 decades. So by then, they have burning pain, they're centrally sensitized, and it's like, I really do believe it's the central nervous system that could be flared, causing the bladder symptoms. It could be the tight muscles from their constipation from when they were 5 that's causing the urinary frequency. So for me, it's like getting a really thorough consult with them. Like, I talk to my patients for, it's like an hour and a half, and then a really thorough physical exam, assessing the pelvic floor, assessing, obviously, for uterosacral nodularity, is the uterus fixed? Like, I can tell with the physical exam, am I expecting deep infiltrating endo or not? Most patients, I'm getting an MRI anyways on, or at least an ultrasound, but I'm ready to do whatever it takes in the OR, and my patients are consulted, risks and benefits, no matter what it is that I find. And if I am suspicious, and I do a cystoscopy with all of my patients anyways, if I do suspect what I'm seeing in my practice, and I've only seen one journal article about the overlap between SIBO and whether you want to call it painful bladder syndrome or interstitial cystitis, it seems to me, and I'd love to hear Maurice's point of view, because they're both histamine mediated, right? Like, in the interstitium, histamine is being released in interstitial cystitis, and that's what's happening in SIBO. And when I have someone who has so many gut issues and a hint of bladder issues, I do find, if I talk to them about low acid, low potassium eating, and I give them guidelines, the more we work on the bladder and the gut concomitantly, I improve their gut issues more so, and their overall pain. So that's just kind of based on, I would love to publish this, but I'm seeing that overlap a ton. And now we're seeing so many patients, like with mast cell activation syndrome and POTS and all of these things that is very highly mast cell activated, whether it's whatever the etiology causing all of these things. So I really feel identifying all the reasons that there is histamine mediation and treating each one of those, and then that impacts the bladder.
I have the problem. That is fascinating. I also think, because you need to sort of think outside of the box, especially when patients have pain that may not be endometriosis related, because your results aren't going to be the same. I wonder, Dr. Chung, what is your approach to a patient? Your approach is very different than everybody else's. What is your approach when you're evaluating a patient? You look at the bladder first, or you look for endometriosis first?
So, patient, first of all, in urogynecology, you get multiple age group, endometriosis groups, like the young one to like maybe 40s, and we have the older populations like 70 to 90s. But first thing I want to ask the question, why are patients with endometriosis come to see us? Is that dysmenorrhea, painful sex, pelvic pain? So we assume that's endometriosis. But if you look back at painful bladder syndrome, they are the same symptoms: pelvic pain, painful sex, dysmenorrhea. So where do we start? And if you go back to Dr. Lowell Parson back in the 90s, talk about patient with chronic pelvic pain, 85% of them have a bladder component. And so you would just have to say that whatever that is, the bladder is going to be involved. Whether you have endometriosis, pelvic pain, it's going to be 85% have part of it. But everybody's presenting symptoms are not the same. Some would just have urinary urgency frequencies. Some would just don't even have that. So if we're going to look at the urinary urgency frequency as one of the hint, we might miss it. And I just assume that the bladder has 85% chances that involved in that particular patient pelvic pain syndrome. So I'll approach the bladder first. It's the easiest thing to do because you don't have to take the patient into operating room and start cutting and poking. So that's where I go after first. And
So I have a comment here. I have a comment here, if it's possible. So there is a difference between the interstitial cystitis or bladder pain syndrome and bladder endometriosis. And that difference is if you're evaluating a patient and only component of the pelvic pain the patient has is the bladder pain, and we can't find any other reasons, like the patient does not have a UTI or anything like that, that needs to be investigated for interstitial cystitis. That's very easy. But if the patient coming and telling me that the patient has dysmenorrhea, the patient has dyspareunia, has a pelvic pain, and has a bladder pain, then I know actually I'm dealing with the bladder endometriosis because there's a reason for it. So that approach is completely different. And to go back to Dr. Orbach, I do think we all evaluating our patient, we all talk to the patient, and also there are multiple questionnaires that American Urogynecology Society are recommending, like a UDI-6, there is a questionnaire that patient, for example, my office patient completing the bunch of questionnaires recommended by American Urogynecology Society and AUA regarding their constipation. Their absolutely constipation can affect the bladder. We all know that. We all know bladder, rectum, and the reproductive system, they're like at 3 levels. Any problem with each level can cause a problem for other ones. So if the patient has a constipation, obviously you control the constipation, bingo, the patient is going to feel better. Because if you don't control the constipation, for example, after sling or something else, patient is going to go to urinary retention. We know that. But however, if patient have a clear pelvic pain and you're suspicious for endometriosis, and in your exam you can you can examine the patient and then actually you can feel the nodule on the uterus circles, then and the patient is also complaining of the urgency frequency, basically OAV symptom, which is aggravated with their menses, and then you have hematuria, then you should investigate the bladder endometriosis. That's pretty obvious. And then affecting the SIBO, I don't know about that completely, about that relationship with the IC. So I'll let Dr. Chung to make a comment about that.
So wait, I'm the host. So I do have a question in that,
Sure.
you know, there's a lot of discussion in the urology world. This is not necessarily an endometriosis thing. So IC is when you have true glomerations inside the bladder, and a painful bladder syndrome, I would say, is sometimes what I call upregulation of the bladder. There's a lot of discussion recently that a true IC is driven by these infections in the biofilm. Are any of you, which
it is true.
We're working on that project.
It's a microbiome. I agree with that. It's a microbiome sensitized the lining of the bladder. That's actually been in the literature recently, and I agree with that, because before that they were kind of treated like maybe it's another allergy or something. Like it's a microbiome in the bladder changing. That is true. I agree with that. And go ahead.
Sorry.
So it's actually over the diagnosis of IC has been changing many years. It was a research diagnosis, we know that, and then there is a clinical diagnosis that AUA has. But overall, I do think sometimes being overdiagnosed because we didn't know what to do with that. We didn't even know it's a changing a microbiome can affect the whole thing. And I do agree, nutrition plays a lot of role, a major role in that. That's I agree with that theory. I agree with that.
Right. There's a lot of discussion. I don't know how many of you are running the microgen tests and things like that. That was, because it's not necessarily when it's not painful bladder and it's not endometriosis, they are finding these infections within the biofilm of the bladder. That's our little project for AUA this month, is that we're working with them talking about that.
So, the urologist was talking about, this is IC. This is the pure IC. The rest of those, they're all not. They're all pelvic floor dysfunctions. Go away. So, but that's not that simple though. And go back to endometriosis in the bladder. I mean, one cannot assume the endometriosis in the bladder are the cause of all the urgency frequencies anyway. And so in the way to approach the patients, I just I'm just approaching in the broad way of looking at the entire person. I can't say that it's bladder endometriosis or peritoneal endometriosis, or is it the irritable voiding symptom. So I approach it the same way as I always been for the last 30 years. As a matter of fact, the paper already submitted and the numbers sustained for the last 30 years. So regardless of whether you have endometriosis in the bladder, invading the bladder, muscularis, but that's easy seen by cystoscopy. But if it's on the peritoneal side, that, as Dr. Serena was saying, oh, well, you get the nerve affecting it, which is very true, that the symptom is nerve symptom. Pain is the nerve pain. So urgency, frequency, all those are nerve symptom. It's not necessarily invading endometriosis symptom. And how do you know this is a nerve or this is actually endometriosis invasion into the muscles? That's easier if you do MRI. Oh yeah, this patient have a couple endometriosis nodules. We know that we have to go and remove those nodules. But in my experience, I would remove and eliminate those symptoms even before I go into excising the endometriosis nodule. That would tell you the reason why I don't go after it right from the beginning. Yes, I know they have disease, but after my evaluation and treatment, the symptoms gone. Again, the urgency is gone, the frequency is gone. Then you can go ahead removing the nodule. The nodule is still there. Now, that's why it's not just that simple. The pelvis is governed by so many nerves. The inferior hypogastric, the pudendal, and whatever you name it, everything in the whole system. So anything that is screwy, the nerve get affected. So my approach is go after the pelvic nerve, and the bladder is the biggest one. And I think Iris know, yes, what I usually do before, and then I branch out.
I actually disagree a little bit. I go after endometriosis first.
Well, we're going
because
to
I
have
know
a discussion.
No.
This is our next discussion. We're going to ask everybody which they do first. So you go first.
Yeah.
Endometriosis first or bladder pain first?
Yeah, because I go after endometriosis first because I do think endometriosis is a generalized inflammation of the body and the pelvic. So it's not just, okay, here's just endometriosis and here is not. Because I do think you have an endometriosis in your pelvic, you can inflame the area. You can inflame the entire pelvic because it's a chronic inflammation. Okay, so it's not just one spot that I can see it. So it's just one place. Why we're doing endometriosis and patient IBS is getting better after that. because the response to the inflammation is less. So I go after endometriosis first. And if my patient have after that OAB symptoms, okay, it's easy. You can give them Meribetriq, you can do a Botox injection, you can do anything else after that. But I go after the endometriosis as something that is affecting the entire pelvic. That's me. Even it might be later needs to be, I don't know, other investigation after that, but I do think I'm going to go after endometriosis first. That's just me. Okay.
Dr. Liu, endometriosis first or bladder pain first?
Yeah, no, I think I'm in the camp of, yeah, you got to excise the disease first. And then afterwards you can, like you said, you can do Myrbetriq, you can do Botox, InterStim, you can do other things. But I mean, it's like if you have a splinter in your finger, you got to remove that splinter first before you just, you can do lidocaine injections, you can do a morphine drip, you can do ketamine cream, you can do whatever. But until you actually remove that splinter, you really aren't going to get the most optimal results in terms of relief of symptoms. And I agree, it's not just that splinter, it's the widespread inflammation that endometriosis can cause. So I agree. I think you should remove the disease first. And hopefully the symptoms improve or resolve. And if they don't, we have other things that can help the pervasive, the persistent symptoms, such as pelvic floor physical therapy, medication, other things that you can do to address any kind of residual symptoms. But sometimes you may not even need it because that splinter is gone and you're like, wow, I feel so great. But
Dr. Iris, you have a different approach, probably. I actually have to say we're probably going to be in the same boat because I don't think it's either or.
Yeah. I mean, listen, you have to individualize care for every patient who comes in. But so I have two patient populations. I have that fertility population who's been trying to get pregnant, who I need to get them to the OR quickly so they can then get pregnant. And then I have like the pain population who also may or may not be desirous of fertility, who I work with tons preoperatively, undoing a lot of their symptoms. So I absolutely, Lori, love you. I totally disagree. I did, after I finished my fellowship, I did start excising first. And then after like 8-10 years, I really changed how I've approached endometriosis, and doing it almost 20 years, like the way that my patients respond to down regulating every single generator of pain before I get them to the OR, my patients overall do so much better. So if I'm suspecting that there's some bladder stuff that could be painful bladder syndrome or interstitial cystitis, right away I'm addressing that. I'm not a medicine doctor. Even though I'm an MD, I like to try not to use medicines because so many of my endo patients are so hypersensitive to so many medicines. So I get them into pelvic floor PT right away. I get them right away on like low acid, low potassium eating. I get them tested for if I think that they have a bacterial overgrowth, which about 80% of my patients do. I get them into integrative nutrition. I get them into meditation, mindfulness, whatever I think is contributing to their pain. And then I see them after 6 weeks. And for many of my patients, some may say I'm 15% better. Some say I'm 50% better. Some are 60% better. And we go and we break down what are they noticing from each intervention, the pelvic floor PT or the breath work or the low acid, low potassium eating. And depending how they're responding, then we decide when I'm going to operate. But most of my patients take between 0 and 2 narcotics. I give them a prescription for it. They all leave with a prescription, but most don't need it because I'm undoing everything before they get to the OR. So I don't get those phone calls. I'm in terrible pain. I'm in this, because what most of them do actually is they thank me in their pre-surgery visit, which is roughly a week before surgery. They're like, now I understand why you wanted me to wait. I feel so much better. My bladder's better. My pelvic floor is better. My bowel movements are better. All these entities. So I literally say to them, what would you think if I operated on you a week after we met and you say your pain is 20% better or 40% better? You'd be like, Dr. Rohrbeck, you're a sucky surgeon. But because I've undone, can I not say that? But
No, you
because
can, but
there's
never.
no, I know, but my point is many are 60% better before I step foot into the OR with them, because 60% often is from all of these other things, or it could be 50. I have many patients who say pelvic floor PT undoes 80% of their pain. I'm not saying that to you because you're a pelvic floor
Right.
PT.
Well, that's the discussion of
But
prehab versus rehab. And
I'm
I think
huge
that,
into prehab. And
right.
my last
And
thing, can I say one
we
more
had,
thing?
yeah,
Their
go ahead.
overall time to getting them better is much shorter when they do prehab.
Yeah. We had the prehab discussion last week. We had Amy, who is your co-author, and we had Ginger Garner. And the discussion of prehab is that especially when somebody has bladder pain, because of the bladder's relationship to S2, 3, and 4, you're gonna get pelvic floor spasms. And so you may not get resolve of those spasms because the endometriosis is also driving them. But to always, and I'm not saying anyone said that they do that, but I see clinics where they do, to always say pelvic floor, oh, that's something for afterwards. It's really a disservice to the patient because there's a lot of work that could be done beforehand.
Correct.
Just switching gears a little bit. Dr. Lori, you have a wonderful situation where you have a multidisciplinary surgical team. Can you talk a little bit about why you have such a involved, you have multiple specialties. In other words, you operate almost exclusively with a urologist almost all the time in these particular cases. What is the advantage of having that at your disposal? We love Dr. Lariche, by the way. Most of our fans will know him, but what is the advantage of having the two surgeons in the room with the two different specialties?
Yeah, I did my fellowship at the Mayo Clinic where I was trained by wonderful GYN oncs, urogynes. We did everything. We didn't ever use any other specialties. We were doing our own LARs, we did everything. So I came out with excellent training in operating on just like at the CEC, you operate on everything. But when I got out to my practice, first of all, sometimes you're having to operate with a resident or a PA, and you really, really don't want to have to depend on your first assist who is brand new, doesn't know what they're doing during a stage 4 endometriosis case. And so I think it's always better for the patient to have two sets of eyes or two attending surgeons or two sets of eyes, one GYN, one urology, sometimes general surgery if needed, or sometimes all the time. I think it's better for the patient to have a multidisciplinary team where you have two sets of eyes, three sets of eyes. We're all focused on the patient. And that way, I feel like you can be a little bit more, I want to say, aggressive with the disease if you have those different specialties there. If we have to do a ureteral reimplantation, I don't know if I would feel comfortable doing that by myself with a first-year resident, even though we did them at Mayo Clinic as a fellow. I don't think that I would want to do that. I think it's better to have the urologist as well as myself, Dr. Lariche, as well as myself doing the ureteral reimplantation together. And a lot of times, most of the time, whether you're going to have to do your ureteral reimplant pre-op. Sometimes you don't. Sometimes you don't know if you're going to have to do an LAR. Sometimes you think you can just shave it, and then you're just like, oh my gosh, this is too much or too lengthy of a bowel to just do a shaving or a disc excision. I'm going to have to do an LAR. You have a general surgeon there. That way, I feel like the patient gets the most complete treatment, the most complete surgery with the lowest risk of having to come back or being told, we did everything we could. We couldn't get it all. You're going to have to come back for a second surgery. So and we have fun in the OR. It's nice to have friends in the OR. It's nice to have that camaraderie ship. You're not on an island. You don't feel so alone. You have supportive colleagues who will support you during the surgery. And God forbid, if there's a complication, you have that support. And I think the patient is going to have a more complete, more thorough, and just better outcomes.
Yes. Dr. Saruna, are you in a multidisciplinary center, or you're Urogyne and you are the man that does everything?
I make it very clear. First of all, I don't anticipate to do a lot of urethral implantation because I'm ready with the stent and everything else. So I have, there's a video we're gonna present that I did the sigmoid resection of the endometriosis nodule and endometriosis with a robot. So if there is a nodule that I can resect, I will do it. I will do my own API. I will do any bladder injury or bladder excision or anything like that. If they're the extreme care, which means they need to be other subspecialties going to come and help me. I have resources of a colorectal friends and then also advanced urologists that specialize in minimally invasive surgery if I have to. And if there is more than that, I usually tell them, it depends on where the location of the lesion is. And if there is a symptomatic or not, because we had patient, for example, if there's a liver involvement, you really don't need to go resect the entire liver, that liver wedge to be asymptomatic. But if you're symptomatic, your liver enzymes are changing, sure, I would send them to the tertiary center to do that. But most of the surgery is going to be done by me. But if there is anything, I definitely have friends in OR to actually assist me in that cases.
Dr. Orbach, are you using multidisciplinary care? Are you operating primarily yourself? What are you choosing?
Always multidisciplinary. I mean, either general surgeon or GYN oncologist or urologist or urogynecologist, just depending. And I have my PA in the OR who's with me on every case as well. So we have like 3 people, like 3 sets of eyes, because I need someone good to manipulate the uterus. I need consistency in the OR. I think that is the key to success in the OR.
Yeah, so we have 2 questions, which I think could be interesting answers, especially from our panel. One is something I hear a lot is that people with bladder pain, either from endometriosis or from the bladder itself, they have a lot of leg pain. We'll start with you, Lori. How do you think the bladder might generate some of that leg pain? They have a lot of heaviness in the legs, burning in the legs. How do you think that's connected?
Yeah, I think we have already touched on that just about, it could be endometriosis, peritoneal endometriosis overlying the pelvic nerves, the hypogastrics, if it's all the way up near the psoas muscle, you got your genitofemoral, ilioinguinal, and all of that can just irritate those pelvic nerves, which can cause the shooting, the shooting pain down the lateral part of the thigh, the anterior part of the thigh, or just sciatica even. I don't think you really see a lot of endometriosis on the actual sciatic nerve, but there's a lot of patients who have sciatic pain during their periods from that referred pain or from the endometriosis that's irritating all the pelvic nerves that run through the pelvis, which also innervates the bladder as well.
Yes, Dr. Iris, do you see a connection between leg pain and bladder related symptoms, bladder endometriosis?
It's so hard.
I do, by the way.
Yeah, I do, but it's also hard to know: is it just the bladder, or is that then causing a spasming of the pelvic floor? Is that there then the coexisting like defecatory dysfunction or like constipation, which is then flaring? I would imagine the answer is yes, but it's hard to tease out which one is causing it.
Dr. Saruna, do you see a connection between the bladder and the leg pain with your patients?
First, we have to know that the most common area that is being involved with the endometriosis in the pelvic are uterosacrals. And the uterosacrals is S2 and S4 passing through that. So patient with the endometriosis, that if they have a bladder endometriosis, yes, the answer is yes, for sure. If they have a bladder endometriosis with involvement in the sidewall, then I'm more actually suspicious of the involvement of the ureters somehow proximal to the bladder that involving the S2 to S4. So those are the alarming signs that I would definitely want to do the MRI for that patient and do a cystoscopy to make sure there's nothing bigger than that is involved for that patient. And actually, when I'm doing a laparoscopy, I pay attention to that area. And that goes back to also getting a history from the patient. Obviously, going back to the previous question, let me finish that. Everybody, we all have help in the OR. I have a PA helping me as well. However, looking at the sides, okay, so there is many ways, like for example, if you have an iris stent that you can also shining through the stent and seeing the ureters, that I can see the depth of the involvement of if there is any deep infiltrative, or if you do the ICG is another way. So yes, if somebody has a bladder endometriosis for sure and has the leg pain with the bladder endometriosis, I'm suspicious involvement of the proximal to the bladder and the ureter together. So that's something that is alarming to me. But if somebody's telling me, oh, I get period and I get have a leg pain, then I know involvement of the urosacral is more common than anything else.
Yes, Dr. Chung, leg pain and the bladder. I know, you're shaking your head because I made you go last.
No, that's okay. I mean, I'm just saying.
Where did he go? Oh, he can't
He's
cut out
mad.
now.
He's mad.
All right. I don't know what happened here. So anyway, all right, if he comes back. The other question that we have is about endometrioma and is that connected? We know that that's in the ovary. How many of you see that related to bladder pain? Hands up for this one. Dr. Lori, do you see that related at all?
I mean, yes, it definitely could be. I mean, if you have an endometrioma, it's very rarely just isolated to the ovary. It's not just when you have an endometrioma, you see on ultrasound, you see on MRI. It's not just you have endometriosis of the ovary and that's it. You know, you can't just go in there and be like, I'm just going to get the cyst out and get it out and call it a day. There's always endometriosis elsewhere in the pelvis, bladder, I mean, it can be anywhere, bladder, bowel. Dr. Orbuck published about, the appendix, and endometriosis in the appendix, especially with the right-sided endometriomas. I mean, it's always everywhere else. It's not just isolated to that ovary. So, I mean, the answer is yes. But some patients too. I mean, Dr. Orbuck was talking about fertility patients. They may not be that symptomatic, they just can't get pregnant and they keep on, or some kind of infertility. They're not that symptomatic. They have no bladder symptoms. And then you get in there and they have the endometrioma and there's endometriosis all over the bladder and they're peeing just fine. They literally have zero symptoms. So endometriosis does not follow the textbook. Everybody is different when it comes to endometriosis. The way their symptoms are, the way they present, it just doesn't follow the rule book. That's why it's so important to have an individualized plan, conversation, workup plan, treatment goals. It's so important to do that for each person because you can't just go through an algorithm as ACOG would have you do, because it's not a one size fits all.
Definitely
I'm back.
not. You are back. Do you want to talk about leg pain in the bladder?
Yeah, I'm just saying that if a patient might have some pelvic floor injury to begin with, you never know whether that patient have endometriosis or the bladder symptom or whatever that is. Anytime when the sacral nerve involved, S2, 3, 4, and it's all going to go to the leg. And some patient with epidural neuralgia, they have leg pain, they have a restless leg syndrome. So this is just part of it. It doesn't mean that the patient have endometriosis on the nerve, or it could just be a visceral somatic sensitizations. And I think I've seen the questions here on the question and answer.
Yeah,
I
we did
just
that
give
one
you,
already.
yeah, I give you an example. I have a patient with stage 4 disease, came in with a huge endometrioma. And all I just gave her is intravesical therapy, and her pain with a VAS score of 10 was brought down to 0, just right in front of me without surgery. Yes, of course, you need to do surgery. The pain is the pain, but that doesn't mean that the pain is from endometrioma or ovarian cyst.
Yeah, it's very interesting. Okay. So this was just a sampling of what goes on at the summit. You can see one of the things I think that's unique about endometriosis is that there is not always an agreement about, the agreement is we need to do good surgery when we do surgery, but the approach is so very different at all times. So the endometriosis summit is coming up. Dr. Lori, maybe your first time in person, what are you looking forward to about the endometriosis summit?
I'm looking forward to seeing everyone in person because it's been my first time really in person since I think I was there for briefly 2020 when it was still in Hoboken. And then after that, it's all been virtual.
I think you had cases till like midnight the night before. So yeah, it'll be nice to see you there. I think, by the way, Dr. Ceruna will be now in 2025 presenting that decades review that he let slip that he has, because that for sure I'm going to feature and we're going to get to work on that. I'm really gonna, but
Iris,
yeah.
Iris, are you going to be there this
I
year?
am going to be in person this year.
Okay, good.
Yes.
Yes.
I'm so excited.
We'll see you there.
It'll be very, very exciting. So I just want to remind people that the Endometriosis Summit is March 8th through the 10th in Orlando, Florida, and virtually. Those of you wondering about MRI and ultrasound, there is a 4 CME course for MDs, which is very, very, our first time doing CME. I don't think you can understand that when you start something basically at your kitchen table and now you're doing CME, it's a really big deal on ultrasound and MRI. And it is available in person and virtual. If you're looking to come in person, I would get those tickets because the room is starting to fill up. So the first is, I'm going to show a little movie. Our doctors probably like 3 out of the 4 have been in the OR all day. And you're probably not going to want to see it, but I wanted to share, I do a lot of work with AUA, and this was part of what we put together to show urologists that bladder pain exists in patients, and it's really the voice of the patient. So I thought tonight is a good night for that. If our doctors log off, that's okay. I'll see us out for the evening, but I thought I would share this since I have it.
So I had chronic UTIs, I had imbalanced pH, pain with urination, back and flank and kidney pain, which I still have today. Anytime my bladder is the least bit full, there's a sense of urgency.
So frequency in urinating, a lot of pain when the bladder is completely full. And then during the relief of the bladder, and then right after, the pain was quite intense.
Doctors would sort of just treat me with antibiotics and just put it down to either UTI, but then coming back on the samples, there was no growth, so there was no infection.
Significant disability if I let my bladder get very full and I'm not able to relieve myself frequently, or if I have a very full bladder. It's actually a trigger.
So the first symptom I ever had was actually urinary. And so I had a bladder that was very irritated, and no matter how little I drank or how much I drank, I had to go to the bathroom probably at least 4 times an hour. Like, it was constant. And I often, if I had a full bladder, I had instances where I had the urge to pee was so overwhelming that I actually peed in public.
So it was about 2 months post total hysterectomy. I started being unable to urinate completely. I felt like my bladder was still full, and I just wasn't able to complete my urination.
I used to have what they would think would be recurrent UTIs, just based on my symptoms, urgency, frequency, burning type pain. But then when a urinalysis was performed, there wasn't evidence of bacteria or anything like that in my urine.
Frequent urination, not feeling like I had been completely emptying my bladder, and then the need to feel like I needed to go urgently.
Damage that endometriosis had done on my bladder is the result of why I cannot urinate anymore, why I'm having hydronephrosis.
Constant urgency, frequency, having to go to the toilet quite a lot. If I didn't go, like, I would get a lot of pain. There was sort of overnight, there would be some nights where I was up about 4 times.
I can see doctors try to figure out, and heard doctors try to figure out whose patient I am.
Sometimes my symptoms are somewhat manageable, and sometimes I can't get out of bed because the urinary symptoms are so painful, the spasms. And yeah, it would be great to have urologists that are more well-rounded and knowledgeable about endometriosis, instead of being like, okay, the gyno will deal with endometriosis when there's also a urinary issue along with it that they might be able to help.
Everyone has to pee. And when you have something you have to do every day that causes a lot of pain, it really wears on you. And sometimes it's even saying that to different physicians, it doesn't always feel like you're being heard. And that's one of the biggest struggles I've had, is to really just try and get my pain across. So that would be my biggest thing. I'd like just urologists to know that the pain is real.
If I had been sent to any urologist or anyone other than just an OB or primary care, I feel like I would have gotten this diagnosis a lot sooner.
I want urologists to be open-minded about the possibility that a 30-year-old woman with urge incontinence, with positive scans, like nothing wrong on those scans, could possibly have endometriosis.
Yeah, I didn't think everybody would stay. So I think we shared that at AUA. We were given the space to do that. And the women that donated their time, I'm so grateful for their voice. But I also will say we made the most headway there with the pediatric urologists who have spent a year calling because they say, like, but why am I having bedwetters that are 11 and 12 years old? What else could be going on? So I feel like those women donated their time, but we made a big difference. I mean, each one, teach one. Maybe if you save one, you're up to it. So that is the end of our program tonight. Next week, I am coming to you from Mayo Clinic. I am joining Mayo for I think it's their Fellows Week. And I'm really excited. And nobody tell Dolly, because she doesn't know I'm leaving for a week yet. And I will see you guys. Don't forget to get your tickets, www.theendometriosissummit.com. Good night, everybody.
Thank you.
Thank you, Sally.
Thank you, everybody.
Thank you.